So the question is, and I'm going to put this out to our panel here, is how often should you screen, and what determines whether you screen at this visit or not screen at this visit? Human, do you want to take that?
Certainly in our state now, if you are in a chronic pain management situation, you are required to have at least one urine drug screen. And from a primary care physician, the urine drug screen, you can do it as often as you want, and you can do it anytime you want, anytime you feel your clinical judgment wants you to do it. And I use the same analogy when it comes to diabetes. Some patients, you ask them to do it 3 times a day, 4 times a day. Sometimes you ask them to do it before meals and after meals. The same exact thing here. Whenever you feel that the patient has to do it, you can ask them to do it. You can do it at each visit. You can do it once a year. You can do it every quarter. You can do it random. You can do it at any time they change the medication. You can do it whenever you suspect that there's something going on. So basically, really, this is depend on completely on a clinical judgment, like exactly what we talked about. Again, your frequency also, I believe that also has some economical impact as well on some patients. You cannot just really do it every week. You cannot do it every 3 weeks. So you have to take everything into consideration. Your risk assessment tool, your patient behavior, your interaction with the patient, and then you lump all that together, and then you do your clinical judgment of whether you want to take the patient to have them urine drug screening frequency. Remember, it is a problem that you're dealing with. Addiction is a serious issue, that it's a serious disease that you have to deal with, and it's like any other disease. It has its own test, and it has its own interpretation, and it has its own clinical judgment that you have to follow.
Some experts will test at every visit, and some experts test once a month, once every 3 months. So there's variability in this, and we already know that the clinical judgment you bring to the table based upon behavior that you can observe often will miss underlying pathology. So you may want to get into your practice a method of doing a regular testing on some interval, month, 3 months, something like that, because you will pick up more tests that will show behavior that you may not observe. Any other ideas about how often to test, Howard?
Well, I'm of the opinion that you don't put a fixed number. I think you test according to the individual patient and your evaluation of his or her risk. And that's part of risk management. And I want to state that the primary care doctor, who they should take care of in these situations. I believe that the primary care doctor is very capable of taking care of chronic pain in a patient who does not have a history of addiction and has no history of a psychiatric disorder. I think they could do a very good job and do a good job in doing that. If the patient has a stable history of a psychiatric disorder, well treated, or has a very firm recovery, that patient you may need a specialist support, either ongoing or visiting the specialist once or twice a year, and he or she may do the testing. And there are certain patients that the primary care doctor shouldn't touch with a 10-foot pole, and that's the patient who gets referred to me, and that patient has an active untreated psychiatric problem or an untreated addiction disorder, and is now willing to work a program for recovery. So again, it comes back to clinical judgment, it comes back to the situation when you do your testing, and it's different for everybody.
God, if you were going to say that they couldn't have a psychiatric disorder and what was the second thing that you said? No history of a substance abuse or psychiatric disorder. God, that's a lot of our population that we're dealing with. So I agree, but if we can't refer all of those patients out because there's way too many large numbers, and the chronic pain population has a higher chance of having a psychiatric disorder and an addiction history. Right. So primary care, I think, can even step up to those intermediate patients with help. Michael,
well, again,
any parting?
You come back to using your clinical judgment based on your time, your education, and your comfort level, and most importantly, your resources in your area, right, who you take care of and who you refer.
Any parting comments on?
Well, Bill, I'd like to put in 2 statements. One is we haven't touched much on the psychiatric comorbidity of these patients, and we worry a lot about addiction and aberrant drug-taking behavior. We really should be looking for depression in these patients, and much aberrant behavior is driven by psychiatric comorbidity, especially depression. As far as testing, the way I like to boil it down is I want my patient to know that testing is possible, but I want them to reach a point where they're not necessarily expecting it at every visit, so that when I do it, there's, in my mind, a greater likelihood that I'll get a snapshot of reality as opposed to something that they're preparing for before the visit with me.
Excellent. So I want to sum up one last time that we have a variety of risk tools that are available that can be valuable in stratifying the patients. That we have the interview with the SOAP and the ORT that are really very predictive. And combined with that is your observation of the behavior. Knowing the patient, knowing the family is the best indicator on which patients are at higher risk and how often to watch them with the urine drug testing. And I want to thank our panel for being so helpful in this topic.